So dear friends, welcome to FA Medical Lectures. So today we will talk about the endocrinology. We will continue, and in that pharmacology subject of endocrinology, we will talk today about the oral antidiabetic drugs, or you may call it as oral hypoglycemic drug or oral anti-hyperglycemic drug, meaning that by any means, if there is hyperglycemia in the body, that will be managed by these drugs, and whatever may be the its etiopathogenesis. Etiopathogenesis we will talk in the pathology, and its biochemistry. Diabetes mellitus is also important, and in physiology as well. So this diabetes mellitus, and this is also one of the global burden creating disease. I am talking about diabetes mellitus, not diabetes insipidus, because diabetes mellitus is due to deficiency of the insulin, that may be either absolute deficiency or relative deficiency. Why I called like this, I will mention further. And then one is there is the diabetes insipidus. So diabetes insipidus is due to deficiency of the antidiuretic hormone, or you may also call it as the vasopressin. So let's enter into the topic, and also we will. I have already uploaded lecture about this insulin physiology, mainly the insulin synthesis and its secretion. You can go and watch there. So you should know first what is the insulin, what is its function, how it is secreted, how it is synthesized, and what could be its clinical feature or complications of its deficiency. Then you can think of its management and its substitute. What substitute can be given, that we will know about from the biochemistry and physiology to know about its function and its management. And also I also used to say time and again that drug, what is drug? Drug is the any substance or product that is used or intended to be used to modify or explore the physiological systems or pathological states, benefits of the recipient or patient. So two terms here: physiological system we can explore or modify by use of the drug, or we can change the pathological state. So I will not consume so much of your time. Let's enter into the topic. So diabetes mellitus is basically due to deficiency of the insulin deficiency, and I also mentioned the diabetes mellitus can be either due to absolute deficiency or due to relative deficiency. Because why I called absolute means basically a broad classification of diabetes mellitus is the type 1 and type 2, and there are various other types of classification and various other types too, that we will talk in the biochemistry and pathology. So for the sake of convenience here, there are two major categories of the diabetes mellitus, type 1 and type 2. In type 1, what happens is that there is the absolute deficiency of the insulin. Absolute deficiency meaning there is the 100% deficiency, either whatever may be the pathophysiology again, there will be the deficiency of the insulin than normal. That may be 100% deficiency, or may be present 20%, 10%, etc. And there is the relative deficiency. Relative deficiency means by any means, if body develops resistance against the insulin, irrespective of the presence of insulin, even at normal level or sometimes more than normal level, due to resistance, its functions will be decreased, will be deranged. So body physiology, what it thinks, there is a deficiency of the insulin, and it will try to manage that. If cannot be managed, then we have to supply the substitute, insulin substitute. So in relative deficiency and this pathology, absolute deficiency, there is the mainly due to destruction of the pancreatic beta cells, because we know the pancreatic beta cells produces the insulin, and in relative deficiency there may not be uh, the destruction of the beta cells, but there will be the resistance, and ultimately the type 2 diabetes mellitus will again turn into the type 1 diabetes mellitus, because if there is relative deficiency, body physiology will try to enhance the secretion of the insulin from the pancreatic beta cells, and in that process, after a long time, again any system uh, its function is limited. Then in that process, self destruction, or due to work overload destruction of pancreatic beta cells occur, and ultimately it will change into the diabetes mellitus type 1. So okay, there is deficiency of the insulin. This is the hormone, so we can replace it by its function, by replacement by the same hormone synthesis, that may be this will be the insulin. We give insulin, then its function we can retain the insulin. There are various preparations of the insulin, and it is also frequently asked the insulin preparation and its type. Short note, very frequently asked. We will talk that too, but in this part, anti-diabetic drugs we will discuss. We will classify mainly. So, insulin sub insulin supplement. Insulin supplement, mainly it is given in the type 1 diabetes mellitus, because there is no resistance, there is a absolute deficiency. And in type 2 diabetes mellitus, type 2, in that we can also give this insulin, but insulin there is the resistance. So if we increase the availability at the receptor site, somehow its function gets enhanced. Say then diabetes mellitus, then question will arise, why we need to if we have insulin, why we need to other drugs? Yes, if you have read about the insulin and rules of drug administration, the insulin being hormone, it is sensitive to digestion if we give orally. So the important uh, disadvantage, we say, the is that it should be given by injection only, and most common route in injection too will be the subcutaneous route, and we can give uh, intramuscular and IV route, through IV route too. And this is also the very frequently asked MCQ and Viva question, like which is the most common route of the insulin injection. From the classification of any drugs, what we should know, it is not just like just we remember the name of the class and its example. No, it gives many clues about its biochemical activity, about its mechanism action, about its uses, contraindication. Before going into the classification, I will talk its brief overview, like what drugs or what agents can be used as the anti-diabetic drugs. So if we know the physiology or biochemistry of the insulin, we can design the drug. Like we know the physiology, like this I have talked about in detail in previous lecture. You can watch their insulin physiology, synthesis and secretion. So let's suppose this is the pancreatic beta cells. In pancreatic beta cells, what happens is that there is the glucose transporter type 2, GLUT 2. Through this transporter, if glucose level increases in the plasma than normal, the glucose uptake will occur through this receptor in the pancreatic beta cells, and as soon as it will enter into the pancreatic beta cells. Glucose will be converted into the glucose 6 phosphate, and glucose 6 phosphate then undergo the glycolysis, Krebs cycle, oxidative phosphorylation, electron transport chain. By all these mechanisms, Krebs cycle, by all these mechanisms, ultimately there will be the production of the ATP. ATP production will be happening there. So, if this insulin ATP level rises in the pancreatic beta cells, there is a ATP sensitive potassium channels, and that through this channel potassium gets leaked outside to maintain the normal resting membrane potential. So if this ATP level will rise, this ATP will block this ATP will block this ATP sensitive potassium channel, and if this happens, the level of potassium will rise inside the pancreatic beta cells, and there is a positive charge increasing inside, meaning it will raise the resting membrane potential towards positive value and depolarize the membrane. During this depolarization process, once a threshold reached, there is calcium channel, and this calcium channel is the voltage gated calcium channel. If depolarization occur here, voltage sensitive channel will open and calcium get influxed inside the pancreatic beta cell. Then what will happen? There is the insulin in the vacuoles of the vesicles of the pancreatic beta cells synthesized insulin. So this calcium will fuse these vesicles, and ultimately it makes the process of exocytosis, and through this exocytosis process insulin normally will be released. So what I am trying to show is that by any means, if we can block this ATP sensitive potassium channel by any other agents, then after this process will be same and insulin will be released. We don't need this normal physiological mechanism. In this way, we can also enhance the insulin secretion. Some agents could be this types, and also if you know the physiology of insulin, in diabetes mellitus, what happens is that there is the hyperglycemia. So hyperglycemia, this is, let's suppose, the small intestine. From there, glucose will be absorbed. By any means. If we block this absorption, then ultimately we can reduce the hyperglycemia. One reason, another reason is that at the nephron loop of the Henle or kidney tubules in the PCT, through the glomerulus and other physiological membrane, what happens? Glucose will also filtered, and this will come to the PCT, and from PCT we know the 100% glucose and amino acid will be reabsorbed, and by any means, if this reabsorption can be blocked by any agent, then what happens? There will not be 100% absorption of the glucose, and ultimately this glucose will pass through the urine, and hyperglycemia again we can reduce. Another reason, mechanism, and after eating, after meal, what happens? Again from this small intestine, there will be the secretion of some hormones called as the incretins. Incretins, this include gastric inhibitory peptide and glucagon like peptide 1. This is also called as the insulinotropic polypeptide. So these hormone what will do by normal physiological mechanism, it will enhance the secretion of the insulin. So, and these hormones are broken down by the enzymes called as the dipeptidyl peptidase 4. Dipeptidyl peptidase 4 is a enzyme that breaks GIP and GLP-1. And if we make its availability prolonged, this will lead to the further secretion of the insulin. So what how we can do this by inhibiting this enzyme that breaks these two peptides. In this way, we can also enhance the insulin secretion. So this is a brief overview. I told already that if you know the physiology and biochemistry, pharmacology is not big deal for you. And classification is not just only like you remember the name of the class and its example. It will be giving various clues about its mechanism action, its usage, its site of action, its adverse effect, and the classification is also important for the questions SAQs. Of course, classification will be frequently asked, and in MCQs too. From the classification, like you will be answered like a question like all of the following are the diabetes inhibitors except, or which of the following drug is falls in this class, this and that. In this way, question will be asked in MCQ and Viva as well. So let's jump into the classification. For classification, you can make a flow chart also, but I will be for the sake of convenience, I will be writing in numbering the class. And for this, I will be taking the reference from the K.D. Tripathi 8th edition South Asia publication edition, and also the reference, also some reference from the Davidson's and Harrison's textbook of medicine. So, and some other book also. So in classification, first and most important group is that insulin secretion enhancer. Class 1 is the insulin secretion enhancer. Insulin secretion enhancer, or we also call it as insulin secretagogues. Insulin secretagogues. Secretagogues means those agents or drugs that will enhance the secretion of the insulin. So it will be further classified into the various subdivision, like mainly the two subdivisions. One is the ATP sensitive potassium channel blockers. ATP sensitive potassium channel blockers, and in this further subtype is number A is the sulfonyl urease. Sulfonyl urease, and another type will be the meglitinides, or we also call it as the phenylalanine analogs. In this, the drugs, there are two generations mainly, first generation and second generation. In first generation, it will include like tolazamide, first generation, tolazamide. Then there will be the chloropropamide and tolbutamide. Tolbutamide and second generation, there are second generation also. Second generation, it will include glibenclamide, glibenclamide, glipizide, gliclazide, glimepiride, glimepiride. These are the drugs under sulfonylureas. Sulfonylureas, and this drug, as I mentioned earlier, it will bind on the sulfonyl mechanism, usage, adverse effect. I will talk in detail in subsequent lecture. Just a brief overview I will give here. Sulfonylureas receptor 1, it will bind there and it will enhance the secretion of the insulin. So now how to remember, if you remember me, it is better. But if you want shortcut, then please remember that Gujarat Titans, you have heard the franchise team of the IPL, Indian Premier League. Gujarat Titans. So from this, these two drugs are removed due to its various either maybe due to toxicity, less efficacy, potency. These drugs are removed. Only tolbutamide of first generation, that too less frequently, is used, and commonly used drugs are the second generation. So omit this one. Remember Gujarat Titans. So how to remember? G. This G, all four names comes have first letter G. So remember G. And also remember this U as a 4, means 4 times G will come, means 4 names will be there starting with G. Then remember T. T means tolbutamide, and Titans S will stand for the sulfonylureas, and this sulfonylureas, and one more shortcut also remember, like 2 gli means starting letter either will be 2 or gli. So this is the mnemonic for the sulfonylureas. And another category includes meglitinides. It will include mainly two, and there are other examples also, but more frequently used. It is the short-acting ATP sensitive blockers, potassium channel blockers. This will be the, it will include repagliflozin and nateglinide. And there is one more example also. I will write one more. There is other examples too. Impagliflozin. Glinide is again meglitinide's common suffix. Then how to remember this? Let's suppose in your college there is a ma'am named Rina ma'am, and who is from the physiology department. So remember, like Rina ma'am of physiology. Physiology. So RE repaglinide, NA natiglinide. This M stands for the meglitinide, and PH stands for the phenylalanine analogs. Okay, now we will talk about another class. We will drop this. In another class, there is called as the, oh sorry. In this uh, insulin secretion enhancer, there is one more class, insulin secretion enhancer or insulin secretagogues. Secretagogues. One more class, type class 2 will be the dipeptidyl peptidase 4 inhibitors, DPP4 inhibitors. DPP4 inhibitors, we already know from this about this DPP4. What is it? It is the enzyme that breaks the incretins GLP1 and GIP. So these enzymes, if we block these enzymes, then its action will be prolonged and insulin secretion will be enhanced. So it will include, and this is the include very important examples. Like for this, I will also give a mnemonic. The mnemonic is that, and also only use this mnemonic for the mnemonic purpose. Like Sita visits Sakhi's town always with Lena. Sita visits Sakhi's town always with Lena. So here will be the sitagliptin. BI will stand for the vildagliptin. SA will stand for the saxagliptin, and this T will stand for the tenigliptin, and AL will stand for the elogliptin. Lena will stand for the linagliptin. So here is also again the gliptin suffix same of this class of the drugs. And remember the mnemonics: Sita visits Sakhi's town. Only take this for the mnemonic purpose. sitagliptin, BI vildagliptin, SA saxagliptin, town T tenigliptin, AL elogliptin, and linagliptin. Now we will talk about the another class. I will type here, like type 2. Class 2 will include those hormones that overcome insulin resistance. resistance. Overcome insulin resistance. So this again this will further classify into two types. Like one will be the biguanide. Biguanides. Biguanides. This will include fenformin, and metformin. Metformin. So this fenformin, due to its lactic acidosis causing effect, or due to its toxicity, it is now removed. It is not used these days. Metformin is commonly used. So this is about the biguanides, and this class will also include one more subtype we call thiazolidinedione, or its this biguanides is also known as the AMPK activator, and this we call as the PPAR gamma. This is gamma, not Y. Gamma activator. It is the nuclear peroxisome proliferator activating receptor gamma. This will include pioglitazone. Now we will move on to the another type. So here will be number 3. We know from the overview I mentioned earlier, there is the if we can block the absorption of the glucose from the intestine, we can also reduce the hyperglycemia. So in that the drugs are we call alpha gluco, please see from the textbook. Alpha glycosidase inhibitors. So again this is the enzyme. So this enzyme will include mainly the sucrase and maltase, and some other like glucoamylase, some other enzymes in the small intestine that will be secreted from the small intestine. And these enzymes, what it will do? It will glucoamylase also. These enzymes will do mainly it will break the disaccharides into the monosaccharides, that is monosaccharides fructose, galactose, glucose, and that are the absorbable form of the carbohydrate. So if we block these enzymes, and these enzymes will also some polysaccharides, some other polysaccharides will be break down into the smaller polysaccharides or monosaccharides. So if we block these enzymes, what happens? There will not be the or less formation of the monosaccharides and less absorbable monosaccharides. So less carbohydrate will be absorbed from the intestine, and that remaining part will pass through the stool, and this will lead to the reduced absorption of the glucose from the intestine, and ultimately this will reduce the hyperglycemia. So if we inhibit this enzyme, normal mechanism of the insulin secretion and digestion secretion will be decreased, and the absorption will be decreased. So this will include acarbose, voglibose, and miglitol. So here you can also make your own mnemonic. And one more type is the like miscellaneous drugs. Some drugs are designed for the other purpose, but also work in this way and reduce the hyperglycemia. Miscellaneous miscellaneous drugs. It will include one class is the yes this will include yes sodium glucose co-transporter type 2 and from the overview what we know, if we reduce or prevent the reabsorption from the proximal convoluted tubules, again 100% glucose will not be reabsorbed and hyperglycemia will be decreased. So this drug block this receptor at the PCT and decrease the reabsorption of the glucose from the PCT. So it will include also remember here one more mnemonic is that Canada's DM. Don't call it as a district magistrate. So this will include canaflogin, DAPA, dapaflogin. So these are the classification of the oral antidiabetic drugs. And one more question will arise, like this oral can these oral anti-diabetic drugs be given in type 1 diabetes mellitus? There is if where there is the absolute deficiency of the insulin. No, almost all these drugs is used for the type 2 diabetes mellitus because some are the insulin secretion enhancer. If there is distracted pancreatic beta cells, how can we enhance the its secretion while there is no pancreatic beta cell or very less? In the same way, overcome insulin resistance. In type 1 diabetes mellitus, there is not insulin resistance. So these drugs are basically for the type 2 diabetes mellitus. More subtype of these miscellaneous drugs will include the dopamine D2 agonist. Dopamine D2 agonist. So it will include examples is the bromocriptine.